Welcome to This Week in Surgery, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Surgery has you covered. Our podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the surgical field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Surgery, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine, including in the operating room. This week in surgery, we will be discussing recently published articles. First, Annals of Surgery. Goal-directed perioperative albumin substitution versus standard of care to reduce postoperative complications, a randomized clinical trial, SuperAdd trial. Objective: to investigate whether goal-directed albumin substitution during surgery and post-anesthesia care to maintain a serum albumin concentration greater than 30 g/L can reduce postoperative complications. Background: hypoalbuminemia is associated with numerous postoperative complications. Since albumin has important physiological functions, substitution of patients with hypoalbuminemia is worth considering. Methods: we conducted a single-center, randomized, controlled, outcome assessor blinded clinical trial in adult patients, American Society of Anesthesiologists Physical Status Classification 3-4 or undergoing high-risk surgery. Patients whose serum albumin concentration dropped less than 30 g/L were randomly assigned to goal-directed albumin substitution maintaining serum concentration greater than 30 g/L or to standard care until discharge from the post-anesthesia intermediate care unit. Standard of care allowed albumin substitution in hemodynamic unstable patients with serum concentration less than 20 g/L only. Primary outcome was the incidence of postoperative complications greater than or equal to 2 according to the Clavin-Dindo classification in at least one of 9 domains: pulmonary, infectious, cardiovascular, neurological, renal, gastrointestinal, wound, pain, and hematological, until postoperative day 15. Results: of 2,509 included patients, 600, 23.9%, developed serum albumin concentrations less than 30 g/L. Human albumin 60 grams, 40 to 80 grams, was substituted to 299, 99.7%, patients in the intervention group and to 54, 18.0%, in the standard care group. At least one postoperative complication classified as Clavin-Dindo classification greater than or equal to 2 occurred in 254 of 300 patients, 84.7%, in the intervention group and in 262 of 300, 87.3%, in the standard treatment group, risk difference -2.7%, 95% C, -8.3% to 2.9%. Conclusion: maintaining serum albumin concentration of greater than 30 g/L perioperatively cannot generally be recommended in high-risk noncardiac surgery patients. Short-term outcomes of different techniques for gastric ischemic preconditioning before esophagectomy, a network meta-analysis. Background: ischemia at the anastomotic site plays a critical role determinant in the development of anastomosis-related complications after esophagectomy. Gastric ischemic conditioning, GIC, before esophagectomy has been described to improve the vascular perfusion at the tip of the gastric conduit with a potential effect on anastomotic leak, L, and stenosis, as risk minimization. Laparoscopic, LAPGIC, and angioembolization, ANGIOGIC, techniques have been reported. Purpose: compare short-term outcomes among different GIC techniques. Materials and methods. Systematic review and network meta-analysis. One-step esophagectomy, NAGIC, LAPGIC, and ANGIOGIC were compared. Primary outcomes were AL, AS, and gastric conduit necrosis, GCN. Risk ratio, RR, and weighted mean difference, WMD, were used as pooled effect size measures, whereas 95% credible intervals, CRIs, were used to assess relative inference. Results: overall, 1,760 patients, 14 studies, were included. Of those, 1,028 patients, 58.4%, underwent NAGIC, 593, 33.6%, Lapgic, and 139, 8%, Unjogic. A.I.O was reduced for Lapgic versus Nogic, RR equals 0.68, 95% Cre 0.47 to 0.98, and Unjogic versus Nogic, RR equals 0.52, 95% Cre 0.31 to 0.93. Similarly, as was reduced for Lapgic versus Nogic, RR equals 0.32, 95% Cre 0.12 to 0.68, and Unjogic versus Nogic, RR equals 1.30, 95% Cre 0.65 to 2.46. The indirect comparison, assessed with the network methodology, did not show any differences for Lapgic versus Unjogic in terms of postoperative AL and as risk. No differences were found for GCN, pulmonary complications, overall complications, hospital length of stay, and 30-day mortality among different treatments. Conclusions. Compared to Nogic, both Lapgic and Unjogic before esophagectomy seem equivalent and associated with a reduced risk for postoperative AL and AS. Psychological distress after inpatient noncardiac surgery, a secondary analysis of the measurement of exercise tolerance before surgery prospective cohort study. Objective: to describe the incidence and natural progression of psychological distress after major surgery. Background: the recovery process after surgery imposes physical and mental burdens that put patients at risk of psychological distress. Understanding the natural course of psychological distress after surgery is critical to supporting the timely and tailored management of high-risk individuals. Methods: we conducted a secondary analysis of the measurement of exercise tolerance before surgery multi-center cohort study, Canada, Australia, New Zealand, and the UK. Measurement of exercise tolerance before surgery recruited adult participants, greater than or equal to 40 years, undergoing elective inpatient noncardiac surgery, and followed them for 1 year. The primary outcome was the severity of psychological distress measured using the anxiety-depression item of EQ-5D 3L. We used cumulative linked mixed models to characterize the time trajectory of psychological distress among relevant patient subgroups. We also explored potential predictors of severe and/or worsened psychological distress at 1 year using multivariable logistic regression models. Results: of 1,546 participants, moderate to severe psychological distress was reported by 32.6% of participants before surgery, 27.3% at 30 days after surgery, and 26.2% at 1 year after surgery. Psychological distress appeared to improve over time among females, odds ratio or 0.80, 95% C, 0.65 to 0.95, and patients undergoing orthopedic procedures, or 0.73, 95% C, 0.55 to 0.91, but not among males, or 0.87, 95% C, 0.87 to 1.07, or patients undergoing non-orthopedic procedures, or 0.95, 95% C, 0.87 to 1.04. Among the average middle-aged adult, there were no time-related changes, or 0.94, 97% C, 0.75 to 1.13, whereas the young old, or 0.89, 95% C, 0.79 to 0.99, and middle old, or 0.87, 95% C, 0.73 to 1.01, had small improvements. Predictors of severe and/or worsened psychological distress at 1 year were younger age, poor self-reported functional capacity, smoking history, and undergoing open surgery. Conclusions: 1/3 of adults experience moderate to severe psychological distress before major elective noncardiac surgery. This distress tends to persist or worsen over time among select patient subgroups. Dynamics of serum CA19-9 in patients undergoing pancreatic cancer resection. Background: carbohydrate antigen, CA19-9 is an established perioperative prognostic biomarker for pancreatic ductal adenocarcinoma, PDAC. However, it is unclear how CA19-9 monitoring should be used during postoperative surveillance to detect recurrence and to guide the initiation of recurrence-focused therapy. Objective: This study aimed to elucidate the value of CA19-9 as a diagnostic biomarker for disease recurrence in patients who underwent DAC resection. Methods: Serum CA19-9 levels at diagnosis, after surgery, and during postoperative follow-up were analyzed in patients who underwent DAC resection. All patients with at least 2 postoperative follow-up CA19-9 measurements before recurrence were included. Patients deemed to be non-secretors of CA19-9 were excluded. The relative increase in postoperative CA19-9 was calculated for each patient by dividing the maximum postoperative CA19-9 value by the first postoperative value. Receiver operating characteristic analysis was performed to identify the optimal threshold for the relative increase in CA19-9 levels to identify recurrence in the training set using Uden's index. The performance of this cutoff was validated in a test set by calculating the area under the curve, AUC, and was compared to the performance of the optimal cutoff for postoperative CA19-9 measurements as a continuous value. In addition, sensitivity, specificity, and predictive values were assessed. Results: in total, 271 patients were included, of whom 208, 77%, developed recurrence. Receiver operating characteristic analysis demonstrated that a relative increase in postoperative serum CA19-9 of 2.6 times was predictive of recurrence, with 58% sensitivity, 83% specificity, 95% positive predictive value, and 28% negative predictive value. The AUC for a 2.6 times relative increase in the CA19-9 level was 0.719 in the training set and 0.663 in the test set. The AUC of postoperative CA19-9 as a continuous value, optimal threshold, 52, was 0.671 in the training set. In the training set, the detection of a 2.6-fold increase in CA19-9 preceded the detection of recurrence by a mean difference of 7 months, p less than 0.001, and in the test set by 10 months, p less than 0.001. Conclusions: a relative increase in the postoperative serum CA19-9 level of 2.6-fold is a stronger predictive marker for recurrence than a continuous CA19-9 cutoff. A relative CA19-9 increase can precede the detection of recurrence on imaging for up to 7 to 10 months. Therefore, CA19-9 dynamics can be used as a biomarker to guide the initiation of recurrence-focused treatment. Development and validation of Hajibandeh Index, ASA status, Sarcopenia, a novel model for predicting mortality after emergency laparotomy. Objectives: to develop and validate a predictive model to predict the risk of postoperative mortality after emergency laparotomy taking into account the following variables: age greater than or equal to 80, ASA status, clinical frailty score, sarcopenia, Hajibandeh index, high, bowel resection, and intraperitoneal contamination. Summary background data. The discriminative powers of the currently available predictive tools range between adequate and strong. None has demonstrated excellent discrimination yet. Methods: the tripod and stroke statement standards were followed to protocol and conduct a retrospective cohort study of adult patients who underwent emergency laparotomy due to non-traumatic acute abdominal pathology between 2017 and 2022. Multivariable binary logistic regression analysis was used to develop and validate the model via 2 protocols, Protocol A and B. The model performance was evaluated in terms of discrimination, ROC curve analysis, calibration diagram and Hosmer-Lemeshow test, and classification table. Results: 1,043 patients were included, statistical power equals 94%. Multivariable analysis kept high, Protocol A, p equals 0.0004, Protocol B, p equals 0.0017, ASA status, Protocol A, p equals 0.0068, Protocol B, p equals 0.0007, and sarcopenia, Protocol A, p less than 0.0001, Protocol B, p less than 0.0001, as final predictors of 30-day postoperative mortality in both protocols, hence the model was called high, ASA status, sarcopenia. The has demonstrated excellent discrimination, AUC, 0.96, p less than 0.0001, excellent calibration, p less than 0.0001, and excellent classification, 95%, via both protocols. Conclusions. The HAS is the first model demonstrating excellent discrimination, calibration, and classification in predicting the risk of 30-day mortality following emergency laparotomy. The HAS model seems promising and is worth attention for external validation using the calculator provided. Next article is from Journal of American Medical Association Surgery. Magnetic seed versus Guidewire breast cancer localization with magnetic lymph node detection, a randomized clinical trial. Objective to determine whether the combination of a paramagnetic seed and supraparamagnetic iron oxide, SPIO, is equivalent to Guidewire SPIO for breast cancer localization and sentinel lymph node detection, SLND. Design, setting, and participants. This was a Phase 3, pragmatic, equivalence, 2-arm, open-label, randomized clinical trial conducted at 3 university and/or community hospitals in Sweden from May 2018 to May 2022. Included in the study were patients with early breast cancer planned for breast conservation and SLND. Study data were analyzed July to November 2022. Interventions. Participants were randomly assigned 1-to-1 to a paramagnetic seed or a Guidewire. All patients underwent SLND with SPIO. Main outcomes and measures: re-excision rate and resection ratio, defined as actual resection volume, optimal resection volume. Results: a total of 426 women, median, IQR, age, 65, 56 to 71 years, median, IQR, tumor size, 11, 8 to 15, were included in the study. The re-excision rate was 2.90%, 95% C, 1.60% to 4.80%, and the median, IQR, resection ratio was 1.96, 1.15 to 3.44. No differences were found between the Guidewire and the seed in re-excisions, 6 of 211, 2.84%, versus 6 of 209, 2.87%, difference, minus 0.03%, 95% C, minus 3.20% to 3.20%, p equals 0.99, or resection ratio, median, 1.93, IQR, 1.18 to 3.43 versus median, 2.01, IQR, 1.11 to 3.47, p equals 0.70. Overall SLN detection was 98.6%, 95% C, 97.1% to 99.4%, with no differences between arms, 203 of 207, 98.1%, versus 204 of 206, 99.0%, difference, minus 0.9%, 95% C, minus 3.6% to 1.8%, p equals 0.72. More failed localizations occurred with the Guidewire, 21 of 208, 10.1%, versus 4 of 215, 1.9%, difference, 8.2%, 95% C, 3.3% to 13.2%, p less than 0.001. Median, IQR, time to specimen excision was shorter for the seed, 15, 10 to 22 minutes versus 18, 12 to 30 minutes, p equals 0.01, as was the total operative time, 69, 56 to 86 minutes versus 75.5, 59 to 101 minutes, p equals 0.03. The experience of surgeons, radiologists, and surgical coordinators was better with the seed. Conclusions and relevance: the combination of SPIO and a paramagnetic seed performed comparably with SPIO and Guidewire for breast cancer conserving surgery and resulted in more successful localizations, shorter operative times, and better experience. Next, we will be discussing articles from British Journal of Surgery. Clinical outcomes after traumatic brain injury and exposure to extracranial surgery, a tract TBI study. Objective: to examine whether exposure to extracranial, EC, surgery and anesthesia is related to worse functional and cognitive outcomes after TBI. Design, setting, and participants. This study was a retrospective, secondary analysis of data from the Transforming Research and Clinical Knowledge in Traumatic Brain Injury, tract TBI, Study, a prospective cohort study that assessed longitudinal outcomes of participants enrolled at 18 level I U.S. trauma centers between February 1, 2014, and August 31, 2018. Participants were 17 years or older, presented within 24 hours of trauma, were admitted to an inpatient unit from the emergency department, had known Glasgow Coma Scale, GCS, and head computed tomography, CT, status, and did not undergo cranial surgery. This analysis was conducted between January 2, 2020, and August 8, 2023. Exposure participants who underwent EC surgery during the index admission were compared with participants with no surgery in groups with a peripheral orthopedic injury or a TBI and were classified as having uncomplicated mild TBI, GCS score of 13 to 15 and negative CT results, CT minus MTBI, complicated mild TBI, GCS score of 13 to 15 and positive CT results, CT plus MTBI, or moderate to severe TBI, GCS score of 3 to 12, M/SB. Main outcomes and measures. The primary outcomes were functional limitations quantified by the Glasgow Outcome Scale extended for all injuries, GOSA all, and brain injury, GOSA TBI, and neurocognitive outcomes at 2 weeks and 6 months after injury. Results: a total of 1835 participants, mean SD, age, 42.2, 17.8, years, 1,279, 70% male, 299 black, 1,412 white, and 96 other were analyzed, including 1,349 non-surgical participants and 486 participants undergoing EC surgery. The participants undergoing EC surgery across all TBI severities had significantly worse GOSA all scores at 2 weeks and 6 months compared with their non-surgical counterparts. At 6 months after injury, M/SB and CT plus MTBI participants who underwent EC surgery had significantly worse GOSA TBI scores, B equals -1.11, 95% C, -1.53 to -0.68, in participants with M/SB and -0.39, 95% C, -0.77 to -0.01, in participants with CT plus MTBI, and performed worse on the trail-making test Part B, B equals 30.1, 95% C, 11.9 to 48.2, in participants with M/SB and 26.3, 95% C, 11.3 to 41.2, in participants with CT plus MTBI. Conclusions and relevance. This study found that exposure to EC surgery and anesthesia was associated with adverse functional outcomes and impaired executive function after TBI. This unfavorable association warrants further investigation of the potential mechanisms and clinical implications that could inform decisions regarding the timing of surgical interventions in patients after TBI. Next we will be discussing articles from Journal of Vascular Surgery. Adjunctive hyperbaric oxygen therapy for spinal cord ischemia after complex aortic repair. Objective: spinal cord ischemia, SCI, with paraplegia or paraparesis is a devastating complication of complex aortic repair, CAR. Treatment includes cerebrospinal fluid drainage, maintenance of hemoglobin concentration, greater than 10 grams/L, and elevating mean arterial blood pressure. Animal and human case series have reported improvements in SCI outcomes with hyperbaric oxygen therapy, HBOT. We reviewed our center's experience with the BOT as a rescue treatment for spinal cord ischemia post-CAR in addition to standard treatment. Methods: a retrospective review of the University Health Network's Hyperbaric Medicine Unit treatment database identified BOT sessions for patients with SCI post-CAR between January 2013 and June 2021. Mean estimates of overall motor function scores were determined for postoperative, pre-BOT, post-BOT, within 4 hours of the final BOT session, and at the final assessment, last available in-hospital of evaluation, using a linear mixed model. A subgroup analysis compared the mean estimates of overall motor function scores between improvement and non-improvement groups at given time points. Improvement of motor function was defined as either a greater than or equal to 2-point increase in overall muscle function score in patients with paraparesis or an upward change in motor deficit categorization, para/monoplegia, paraparesis, and no deficit. Subgroup analysis was performed by stratifying by improvement or non-improvement of motor function from pre-FOT to final evaluation. Results: 30 patients were treated for SCI. Pre-FOT, the motor deficit categorization was 10 paraplegia, 3 monoplegia, 16 paraparesis, and 1 unable to assess. At the final assessment, 14 patients demonstrated variable degrees of motor function improvement, 8 patients demonstrated full motor function recovery. 7 of the 10 patients with paraplegia remained paraplegic despite FOT. The estimated mean of overall muscle function score for pre-FOT was 16.6 plus or minus 2.9, 95% confidence interval, C, 10.9 to 22.3, and for final assessment was 23.4 plus or minus 2.9, 95% C, 17.7 to 29.1. The estimated mean difference between pre-FOT and final assessment overall muscle function score was 6.7 plus or minus 3.1, 95% C, 0.6 to 16.1. The estimated mean difference of the overall muscle function score between pre-FOT and final assessment for the improved group was 16.6 plus or minus 3.5, 95% C, 7.5 to 25.7, versus minus 4.9 plus or minus 4.2, 95% C, minus 16.0 to 6.2, for the non-improved group. Conclusions: FOT, in addition to standard treatment, may potentially improve recovery in spinal cord function following SCI post-CAR. However, the potential benefits of FOT are not equally distributed among subgroups. Association of polypharmacy scores with the long-term survival of patients with intact aortoiliac aneurysms and indication for repair. Objective/background. Our study analyzed the relationship between two polypharmacy scores, addition of chronic prescribed drugs, ACPDs, and RX risk comorbidity index, and survival in patients with an intact abdominal aortic and/or common iliac aneurysm, AAA. Methods: consecutive retrospective, single-center cohort of patients attended for an intact AAA with indication for repair from 2008 to 2021. Demographic data: Charlson Comorbidity Index, AAA treatment, ACPD, and RX risk polypharmacy scores were recorded at baseline. Main outcomes were the 5-year and long-term survival rates. The statistical analysis included Cox regression, area under the curve, and continuous net reclassification index. Results: a total of 424 patients with AAA were evaluated, median age, 76 years, 92.2% male, median Charlson Index 2, of whom 314, 74.1%, underwent intervention, 80% endovascular and 20% open, and 110, 25.9%, did not. During follow-up, mean 4.6 years, 245 patients, 57.8% died, with 1 month, 1 year, and 5-year survival rates of 98.1%, 86.3%, and 52.7%, respectively. ACPD and RX risk indices, median, interquartile range, 6, 4 to 9, and 3, 0 to 5, respectively, were significantly and linearly associated, p less than 0.001, with survival, with the best cutoff points at 5 and 0, respectively. An ACPD greater than 5, patients with greater than 5 chronically prescribed drugs at baseline, and an RX risk greater than 0 were associated with a 45.2%, p equals 0.038, and 102%, p equals 0.002, increase in 5-year mortality, respectively, after adjustment for age, sex, Charlson Index, and type of AAA treatment. Both polypharmacy indices improved significantly the discriminative power of the Charlson Comorbidity Index in predicting survival. Conclusions: both ACPD and RX risk polypharmacy scores are independently related to survival among patients with an intact AAA and indication for repair. Their behavior is similar, so the simple ACPD greater than 5 appears to be sufficient to identify patients with lower survival rates. Clinical outcomes of MANTA closure device in percutaneous endovascular aortic aneurysm repair. Objective: The MANTA device is a plug-based vascular closure device, VCD, designed for large-bore femoral arterial access site closure. It showed promising results in transcatheter aortic valve replacement cases. In this study, we report our results and evaluate the MANTA VCD in percutaneous endovascular aortic aneurysm repair, PVAR. Methods. All data of consecutive patients who underwent an elective PVAR between October 2018 and December 2022 were retrospectively reviewed. In all patients, at least one common femoral artery was intended to close with a MANTA VCD. Depending on the sheath size, the 14FR or 18FR MANTA VCD was used. On the preoperative computed tomography scan, the diameter of the common femoral artery, CFA, was measured and the amount of calcification based on the peripheral arterial calcium scoring system, PICS, was scored. Primary outcome was procedural technical success. Procedural technical success was defined as placement of the MANTA closure device resulting in vascular closure with patent CFA, without requiring immediate open or endovascular surgery. The secondary outcomes were access site complications requiring reintervention and all-cause mortality at 30-day follow-up. Results. In total, 152 consecutive patients underwent PVAR with 291 common femoral artery closure procedures with a MANTA VCD. Mean age was 74.1 plus or minus 6.4 years, with a mean body mass index of 27.7 plus or minus 4.4 kilograms/m2. The mean diameter of the CFA was 10.5 plus or minus 1.9 millimeters. In 52.6% of the cases, there were no calcification on the preoperative computed tomography scan. The 18FR and 14FR MANTA VCD were used 169 and 122 times, respectively. The technical success rate was 96.6%. Major vascular complications were reported in 4.5% of the cases, without any death-related events. Conclusions. This single-center retrospective cohort study analyzed the procedural technical success, major vascular complications and all-cause mortality at 30-day follow-up of the MANTA vascular closure device in 152 PVAR patients with 291 common femoral artery closure procedures. The technical success rate was 96.6%. Major vascular complications were reported in 4.5% of the cases, without any death-related events. We concluded that the MANTA device is a safe and feasible option with a high rate of technical success in patients undergoing PVAR. Clinical outcomes of MANTA closure device in percutaneous endovascular aortic aneurysm repair. Objective. The MANTA device is a plug-based vascular closure device, VCD, designed for large-bore femoral arterial access site closure. It showed promising results in transcatheter aortic valve replacement cases. In this study, we report our results and evaluate the MANTA VCD in percutaneous endovascular aortic aneurysm repair, PVAR. Methods. All data of consecutive patients who underwent an elective PVAR between October 2018 and December 2022 were retrospectively reviewed. In all patients, at least one common femoral artery was intended to close with a MANTA VCD. Depending on the sheath size, the 14FR or 18FR MANTA VCD was used. On the preoperative computed tomography scan, the diameter of the common femoral artery, CFA, was measured and the amount of calcification based on the peripheral arterial calcium scoring system, PICS, was scored. Primary outcome was procedural technical success. Procedural technical success was defined as placement of the MANTA closure device resulting in vascular closure with patent CFA, without requiring immediate open or endovascular surgery. The secondary outcomes were access site complications requiring reintervention and all-cause mortality at 30-day follow-up. Results. In total, 152 consecutive patients underwent PVAR with 291 common femoral artery closure procedures with a MANTA VCD. Mean age was 74.1 plus or minus 6.4 years, with a mean body mass index of 27.7 plus or minus 4.4 kilograms/m2. The mean diameter of the CFA was 10.5 plus or minus 1.9 millimeters. In 52.6% of the cases, there were no calcification on the preoperative computed tomography scan. The 18FR and 14FR MANTA VCD were used 169 and 122 times, respectively. The technical success rate was 96.6%. Major vascular complications were reported in 4.5% of the cases, without any death-related events. Conclusions. This single-center retrospective cohort study analyzed the procedural technical success, major vascular complications and all-cause mortality at 30-day follow-up of the MANTA vascular closure device in 152 PVAR patients with 291 common femoral artery closure procedures. The technical success rate was 96.6%. Major vascular complications were reported in 4.5% of the cases, without any death-related events. We concluded that the MANTA device is a safe and feasible option with a high rate of technical success in patients undergoing PVAR. Direct oral anticoagulants over warfarin at discharge associated with improved survival and patency in infrageniculate bypasses with prosthetic conduits. Objective. There is no consensus on the optimal anticoagulant regimen following lower extremity bypass. Historically, warfarin has been utilized for prosthetic or compromised vein bypasses. Direct-acting oral anticoagulants, DOACs, are increasingly replacing warfarin in this context, but their efficacy in bypass preservation has not been well studied. Recent studies have shown that DOACs may improve outcomes following bypasses, however, it is unclear if this is dependent upon type of bypass conduit. The goal of this study was to evaluate whether a difference exists between vein and prosthetic infrageniculate bypasses outcomes based on the anticoagulant utilized on discharge, warfarin or DOAC. Methods. The Vascular Quality Initiative infrainguinal bypass database was queried for all patients who underwent an infrageniculate bypass and were anticoagulation naive at baseline but were discharged on either warfarin or DOACs. A survival analysis was performed for patients up to 1 year to determine whether the choice of discharge anticoagulation was associated with differences between those with vein versus prosthetic conduits in overall survival, primary patency, risk of amputation, or risk of major adverse limb events, MALE. A multivariable Cox proportional hazards analysis was performed to control for differences in baseline demographic factors between the groups. Results. During the study period, 2003 to 2020, 57,887 patients underwent infrageniculate bypass. Of these, 3,230, 5.5%, were anticoagulated on discharge. There was a similar distribution of anticoagulation between vein, N equals 1,659, 51.4%, and prosthetic conduits, N equals 1,571, 48.6%. 32% were discharged on DOACs, and 68.0% were discharged on warfarin. For prosthetic conduits, being discharged on a DOAC was associated with improved outcomes on univariate and multivariable analyses revealing lower risk of overall mortality. Hazard ratio, HR, 0.61, 95% confidence interval, C, 0.41 to 0.93, P equals 0.021, loss of primary patency, HR, 0.70, 95% C, 0.55 to 0.89, P equals 0.003, risk of amputation, HR, 0.71, 95% C, 0.54 to 0.93, P equals 0.013, and risk of MALE, HR, 0.80, 95% C, 0.64 to 1.00, P equals 0.048. Patients with a vein bypass had improved univariate outcomes for survival and primary patency. However, with multivariable analysis, there were no significant differences in outcomes between DOAC and warfarin. Conclusions. Anticoagulation-naive patients who underwent an infrageniculate prosthetic bypass had higher rates of overall survival, bypass patency, amputation-free survival, and freedom from MALE when discharged on a DOAC compared with warfarin. Those with vein bypasses had similar outcomes regardless of the choice of anticoagulation. Next article is from Surgical Endoscopy. Incidence and risk factors of metachronous contralateral inguinal hernia development up to 25 years after unilateral inguinal hernia repair, a single-center retrospective cohort study. Background: patients undergoing unilateral inguinal hernia repair (IHR) are at risk of metachronous contralateral inguinal hernia (MCIH) development. We evaluated incidence and risk factors of MCI development up to 25 years after unilateral IHR to determine possible indications for concomitant prophylactic surgery of the contralateral groin at the time of primary surgery. Methods: patients between 18 and 70 years of age undergoing elective unilateral IHR in the University Hospital of Leuven from 1995 to 1999 were studied retrospectively using the electronic health records and prospectively via phone calls. Study aims were MCI incidence and risk factor determination. Kaplan-Meier curves were constructed and univariable and multivariable Cox regressions were performed. Results: 758 patients were included, 91% male, median age 53 years. Median follow-up time was 21.75 years. The incidence of operated MCI after 5 years was 5.6%, after 15 years 16.1%, and after 25 years 24.7%. The incidence of both operated and non-operated MCI after 5 years was 5.9%, after 15 years 16.7%, and after 25 years 29.0%. MCI risk increased with older age and decreased in primary right-sided IHR and higher BMI at primary surgery. Conclusion: the overall incidence of MCI after 25-year follow-up is 29.0%. Potential risk factors for the development of a MCI are primary left-sided inguinal hernia repair, lower BMI, and older age. When considering prophylactic repair, we suggest a patient-specific approach taking into account these risk factors, the surgical approach, and the risk factors for chronic postoperative inguinal pain. The correlation between the main and minor lesions of synchronous multiple gastric neoplasms assessed gastroscopically and microscopically. Background: patients with early gastric cancer, EGC, are at high risk of developing synchronous multiple gastric neoplasms, SMGNs, after undergoing endoscopic submucosal dissection, ESD. However, most previous studies have had small sample sizes, and few have focused on association studies. Aims: this study aimed to analyze the associations between SMGN lesion data from patients with EGC treated with ESD and their correlation coefficients. Methods: the clinical ESD data from 2 hospitals from January 2008 to January 2021 were retrospectively analyzed. The main lesions were defined as those with a significant depth of infiltration. The larger tumor diameter was considered the main lesion if the lesions had the same infiltration depth. Results: of the 1,013 post-ESD cases examined, 95 cases, 223 lesions, had SMGN, and 25 patients had more than 3 lesions. For the correlation analysis, 190 lesions were included. The study revealed a similarity in pathological type between main and minor lesions, RS equals 0.37, and a positive correlation in infiltration depth, RS equals 0.58. The mean diameter sizes of the main and minor lesions were 20.7 plus or minus 8.3 mm and 13.1 plus or minus 6.4 mm, respectively, with statistically significant differences, p less than 0.001. A linear correlation was observed between the diameter size, and a linear regression model was constructed, producing R equals 0.38, 95% confidence interval, C 0.19 to 0.54, B equals 0.29, 95% C 0.14 to 0.44, T equals 3.94, P less than 0.001. A correlation was identified between the vertical distribution of the main and minor lesions, the horizontal distribution, and the gross endoscopic morphology, phi C equals 0.25, P equals 0.02, phi C equals 0.32, P less than 0.001, phi C equals 0.60, P less than 0.001. Conclusions: the correlation coefficients for microscopic characteristics were higher than those for gastroscopy. There is a significant positive correlation between the main and minor lesions regarding pathological stage and depth of infiltration, respectively. The spatial distribution of the lesions and the gastroscopic morphology were similar. Next article is from Annals of Surgical Oncology. Access, Outcomes, and Costs Associated with Surgery for Malignancy Among People Experiencing Homelessness. Background. Little is known about surgery for malignancy among people experiencing homelessness, PEH. Poor healthcare access may lead to delayed diagnosis and need for unplanned surgery. This study aimed to 1. Characterize access to care among PEH, 2. Evaluate postoperative outcomes, and 3. Assess costs associated with surgery for malignancy among PEH. Methods. This was a retrospective cohort study of patients in the Healthcare Cost and Utilization Project, HCUP, who underwent surgery in Florida, New York, or Massachusetts for gastrointestinal or lung cancer from 2016 to 2017. PEH were identified using CUP's homeless variable and ICD-10 code Z59. Multivariable regression models controlling patient and hospital variables evaluated associations between homelessness and postoperative morbidity, length of stay, LOS, 30-day readmission, and hospitalization costs. Results. Of 67,034 patients at 566 hospitals, 98.2% were PEH. Most PEH, 44.9%, underwent surgery for colorectal cancer. PEH more frequently underwent unplanned surgery than housed patients, 65.3% versus 23.7%, odds ratio, or 5.17, 95% confidence interval, c. 3.00 to 8.92, and less often were treated at cancer centers, 66.0% versus 76.2%, p equals 0.02. Morbidity rates were similar between groups, 20.4% versus 14.5%, p equals 0.10. However, PEH demonstrated higher odds of facility discharge, or 5.89, 95% c. 3.50 to 9.78, and readmission, or 1.81, 95% c. 1.07 to 3.05, as well as 67.7% longer adjusted loss, 95% c. 42.0 to 98.2%. Adjusted costs were 32.7% higher, 95% c. 14.5 to 53.9%, among PEH. Conclusions. PEH demonstrated increased odds of unplanned surgery, longer loss, and increased costs. These results underscore a need for improved access to oncologic care for PEH. Next article is from Obesity Surgery. Evaluation of healthcare utilization and expenditures in persons with type 2 diabetes undergoing bariatric metabolic surgery. Purpose. Changes in healthcare utilization and expenditures after bariatric metabolic surgery, BMS, for people with type 2 diabetes mellitus, T2DM, are unclear. We use the Dutch National All-Payer Claims Database, APCD, to evaluate utilization and expenditures in people with T2DM who underwent BMS. Methods. In this cohort study, patients with T2DM who had BMS in 2016 were identified in the APCD. This group was matched 1:2 to a control group with T2DM who did not undergo BMS based on age, gender, and healthcare expenditures. Data on healthcare expenditures and utilization were collected for 2013 to 2019. Results. In total, 1,751 patients were included in the surgery group and 3,502 in the control group. After BMS, total median expenditures in the surgery group stabilized, €3,156 to €3,120, and increased in the control group, €3,174 to €3,434. Total pharmaceutical expenditures decreased 28% in the surgery group, €957 to €494, and increased 55% in the control group, €605 to €936. In the surgery group, 67.1% did not use medication for T2DM in 2019 compared to 13.3% in the control group. Healthcare use for microvascular complications increased in the control group, but not in the surgery group. Conclusion. BMS in people with T2DM stabilizes healthcare expenditures and decreases medication use and care use for microvascular complications. In contrast, healthcare use and expenditures in T2DM patients who do not undergo surgery gradually increase over time. Due to the progressive nature of T2DM, it is expected that these differences will become larger in the long term. Plasma SHBG levels as an early predictor of response to bariatric surgery. Background: obesity is a growing global health problem, and currently, bariatric surgery (BS) is the best solution in terms of sustained total weight loss (TWL). However, a significant number of patients present weight regain (WR) in time. There is a lack of biomarkers predicting the response to BS and WR during the follow-up. Plasma SHBG levels, which are low in obesity, increase 1 month after BS, but there is no data of plasma SHBG levels at long term. We performed the present study aimed at exploring the SHBG role in predicting TWL and WR after BS. Methods: prospective study including 62 patients with obesity undergoing BS. Anthropometric and biochemical variables, including SHBG, were analyzed at baseline, 1, 6, 12, and 24 months. TWL greater than or equal to 25% was considered as good BS response. Results: weight loss nadir was achieved at 12 months post-BS, where maximum SHBG increase was reached. Greater than or equal to 25% TWL patients presented significantly higher SHBG increases at the first and 6th months of follow-up with respect to baseline, 100% and 150% respectively, p equals 0.025, then less than 25% TWL patients, 40% and 50% respectively, p equals 0.03. Also, these presented 6.6% WR after 24 months. The first month SHBG increase predicted BS response at 24 months, or equals 2.71, 95% C equals 1.11 to 6.60, p equals 0.028, and TWL in the 12th month, R equals 0.330, p equals 0.012, and the WR in the 24th, R equals minus 0.301, p equals 0.028. Conclusions: our results showed for the first time that increase in plasma SHBG levels within the first month after BS is a good predictor of TWL and WR response after 2 years. Comparing the impact of three-dimensional digital visualization technology versus traditional microscopy on microsurgeons in microsurgery, a prospective self-controlled study. Background: emerging three-dimensional digital visualization technology, DVT, provides more advantages than traditional microscopy in microsurgery. However, its impact on microsurgeons' visual and nervous systems and delicate microsurgery is still unclear, which hinders the wider implementation of DVT in digital visualization for microsurgery. Methods and material: 42 microsurgeons from the Zhongshan Ophthalmic Center were enrolled in this prospective self-controlled study. Each microsurgeon consecutively performed 30 minutes conjunctival sutures using a three-dimensional digital display and a microscope, respectively. Visual function, autonomic nerve activity, and subjective symptoms were evaluated before and immediately after the operation. Visual functions, including accommodative lag, accommodative amplitude, near point of convergence and contrast sensitivity function, CSF, were measured by an expert optometrist. Heart rate variability was recorded by a wearable device for monitoring autonomic nervous activity. Subjective symptoms were evaluated by questionnaires. Microsurgical performance was assessed by the video-based objective structured assessment of technical skill, OSATS, tool. Results: accommodative lag decreased from 0.63, 0.18 diopters, D, to 0.55, 0.16, D, p equals 0.014. Area under the log contrast sensitivity function increased from 1.49, 0.15, to 1.52, 0.14, p equals 0.037, and heart rate variability decreased from 36.00, 13.54 milliseconds, ms, to 32.26, 12.35 ms, p equals 0.004, after using the DVT, but the changes showed no differences compared to traditional microscopy, p greater than 0.05. No statistical significance was observed for global OSAT scores between the 2 rounds of operations, mean difference, 0.05, 95% C, minus 1.17 to 1.08 points, p equals 0.95. Subjective symptoms were quite mild after using both techniques. Conclusions. The impact of DVT-based procedures on microsurgeons includes enhanced accommodation and sympathetic activity, but the changes in surgical performance are not significantly different from those of microscopy-based microsurgery. Our findings indicate that short-term use of DVT is reliable for microsurgery, and the long-term effect of using DVT deserve more Trends and benefits of early hip arthroplasty for femoral neck fracture in China, a national cohort study. Background. Limited studies have examined the benefits of early arthroplasty within 48 hours from admission to surgery for femoral neck fractures, FNFs. Using the National Inpatient Database, the authors aim to investigate the trends in early arthroplasty within 48 hours for FNFs in China and to assess its effect on in-hospital complications and 30-day readmission patterns. Materials and methods. This was a retrospective cohort study. Patients receiving primary total hip arthroplasty (THA) or hemiarthroplasty (HA) for FNFs in the hospital quality monitoring system between 2013 and 2019 were included. After adjusting for potential confounders with propensity score matching, a logistic regression model was performed to compare the differences in in-hospital complications, i.e. in-hospital death, pulmonary embolism, deep vein thrombosis, DVT, wound infection, and blood transfusion, rates and causes of 30-day readmission between early and delayed arthroplasty. Results. During the study period, the rate of early THA increased from 18.0 to 19.9%, and the rate of early HA increased from 14.7 to 18.4%, p less than 0.001. After matching, 11,731 pairs receiving THA and 13,568 pairs receiving HA were included. Compared with delayed THA, early THA was associated with a lower risk of pulmonary embolism, odds ratio, or 0.51, 95% C, 0.30 to 0.88, DVT, or 0.59, 95% C, 0.50 to 0.70, blood transfusion, or 0.62, 95% C, 0.55 to 0.70, 30-day readmission, or 0.82, 95% C, 0.70 to 0.95, and venous thromboembolism-related readmission, or 0.50, 95% C, 0.34 to 0.74. Similarly, early HA was associated with a lower risk of DVT, or 0.70, 95% C, 0.61 to 0.80, and blood transfusion, or 0.74, 95% C, 0.68 to 0.81, than delayed HA. Conclusion. Despite a slight increase, the rate of early arthroplasty remained at a low level in China. Given that early arthroplasty can significantly improve prognosis, more efforts are needed to optimize the procedure and shorten the time to surgery. Next article is from Journal of the American College of Surgeons: Effect of Smoke Evacuator on Reduction of Volatile Organic Compounds and Particles in Surgical Smoke, a randomized controlled trial. Background. Surgical smoke is an occupational health problem and is increasingly recognized as a potential source of virus transmission. Dedicated smoke evacuators are used to protect against surgical smoke exposure. We tested the hypothesis that using smoke evacuators would reduce volatile organic compounds and the number of particles in surgical smoke during the laparotomy procedure. Study design. A randomized, double-blind clinical trial was conducted in patients undergoing laparotomy from June 11, 2021, to March 30, 2022, to compare the effectiveness of smoke evacuators with a control. Registration, Human 000044250. The primary outcome was a change in the acetaldehyde level. Secondary outcomes were changes in the formaldehyde level and particle count assessed by the particle size of 0.3, 0.5, 1.0, and 5.0 nm. Results. A total of 42 patients were randomized and assessed, smoke evacuator group, N equals 22 versus control group, N equals 20. The acetaldehyde level was significantly lower in the smoke evacuator group than in the control group, mean 95% C, 10.6, 3.7 to 17.5, versus 47.2, 19.9 to 74.5 G/M3, p less than 0.001. Similarly, the formaldehyde level was 72.2% lower in the smoke evacuator group than in the control group. Particle counts by each particle size category were 80% to 95% lower in the smoke evacuator group than in the control group, all p less than 0.001. Conclusions. Dedicated smoke evacuators reduced the level of acetaldehyde and formaldehyde, and the number of particles in surgical smoke, minimizing the potential exposure to volatile organic compounds and particle matters during surgery. Use of perioperative advanced practice providers to reduce cost and readmission in the postoperative hepatopancreatobiliary population, results of a simulation study. Background. Postoperative healthcare use and readmissions are common among the hepatopancreatobiliary (HPB) population. We evaluated the surgical volume required to sustain advanced practice providers (APPs) in the perioperative setting for cost reduction. Study design. Using decision analysis modeling, we evaluated costs of employing dedicated perioperative app navigators compared with no apps navigators. Simulated subjects could 1. Present to an emergency department, with or without readmission, 2. Present for direct readmission, 3. Require additional office visits, or 4. Require no additional care. We informed our model using the most current available published data and performed sensitivity analyses to evaluate thresholds under which dedicated perioperative app navigators are beneficial. Results. Subjects within the app navigator cohort accumulated $1,270 and a readmission rate of 6.9%, compared with $2,170 and 13.5% with no app navigators, yielding a cost savings of $905 and 48% relative reduction in readmission. Based on these estimated cost savings and national salary ranges, a perioperative apps become financially self-sustaining with 113 to 139 annual HPB cases, equating to 2 to 3 HPB cases weekly. Sensitivity analyses revealed that perioperative app navigators were no longer cost-saving when direct readmission rates exceeded 8.9%, base case 3.7%. Conclusions. We show that readmissions are reduced by nearly 50% with an associated cost savings of $900 when employing dedicated perioperative apps. This position becomes financially self-sufficient with an annual HPB case load of 113 to 139 cases. High-volume HPB centers could benefit from post-discharge app navigators to optimize outcomes, minimize high-value resource use, and ultimately save cost. Next article is from Journal of Trauma and Acute Care Surgery. The interaction between geriatric and neighborhood vulnerability, delineating pre-hospital risk among older adult emergency general surgery patients. Background. When presenting for emergency general surgery, EGS, care, older adults frequently experience increased risk of adverse outcomes owing to factors related to age, geriatric vulnerability, and the social determinants of health unique to the places in which they live, neighborhood vulnerability. Little is known about how such factors collectively influence adverse outcomes. We sought to explore how the interaction between geriatric and neighborhood vulnerability influences EGS outcomes among older adults. Methods. Older adults, 65 years or older, hospitalized with an OS-defined EGS condition were identified in the 2016 to 2019, 2021 Florida State Inpatient Database. Latent variable models combined the influence of patient age, multimorbidity, and hospital frailty risk scoring to a single metric of geriatric vulnerability. Variations in geriatric vulnerability were then compared across differences in neighborhood vulnerability as measured by variations in Area Deprivation Index, Social Vulnerability Index, and their corresponding subthemes, for example, access to transportation. Results. A total of 448,968 older adults were included. For patients living in the least vulnerable neighborhoods, increasing geriatric vulnerability resulted in up to 6 times greater risk of death, 30-day risk-adjusted hazards ratio, HR, 6.32, 95% confidence interval, C, 4.49 to 8.89. The effect was more than doubled among patients living in the most vulnerable neighborhoods, where increasing geriatric vulnerability resulted in up to 15 times greater risk of death, 30-day risk-adjusted HR, 15.12, 95% C, 12.57 to 18.19. When restricted to racial/ethnic minority patients, the multiplicative effect was 4 times as high, resulting in corresponding 30-day HRs for mortality of 11.53, 95% C, 4.51 to 29.44, versus 40.67, 95% C, 22.73 to 72.78. Similar patterns were seen for death within 365 days. Conclusion: both geriatric and neighborhood vulnerability have been shown to affect pre-hospital risk among older patients. The results of this study build on that work, presenting the first in-depth look at the powerful multiplicative interaction between these two factors. The results show that where a patient resides can fundamentally alter expected outcomes for EGS care such that otherwise less vulnerable patients become functionally equivalent to those who are, at baseline, more aged, more frail, and more sick. Next article is from the American Journal of Surgery. Social vulnerability is associated with higher risk-adjusted rates of postoperative complications in a broad surgical population. Objective: the purpose of this study was to determine if an association between Social Vulnerability Index, SVI, and risk-adjusted complications exists in a broad spectrum of surgical patients. Summary background data. Growing evidence supports the impact of social circumstances on surgical outcomes. SVI is a neighborhood-based measure accounting for socio-demographic factors putting communities at risk. Methods. This was a multi-hospital, retrospective cohort study including a sample of patients within one healthcare system, 2012 to 2017. Patient addresses were geocoded to determine census tract of residence and estimate SVI. Patients were grouped into low SVI, score less than 75, and high SVI, score greater than or equal to 75, cohorts. Perioperative variables and postoperative outcomes were tracked and compared using local ACS and SCOP data. Multivariable logistic regression was performed to generate risk-adjusted odds ratios of postoperative complications in the high SVI cohort. Results. Overall, 31,224 patients from 5 hospitals were included. Patients with high SVI were more likely to be racial minorities, have 12-18 medical comorbidities, have high ASA class, be functionally dependent, be treated at academic hospitals, and undergo emergency operations, all p less than 0.05. Patients with high SVI had significantly higher rates of 30-day mortality, overall morbidity, respiratory, cardiac and infectious complications, urinary tract infections, postoperative bleeding, non-home discharge, and unplanned readmissions, all p less than 0.05. After risk adjustment, only the associations between high SVI and mortality and unplanned readmission became non-significant. Conclusions. High SVI was associated with multiple adverse outcomes even after risk adjustment for preoperative clinical factors. Targeted preventative interventions to mitigate risk of these specific complications should be considered in this high-risk population. Survival benefits of extensive surgery in patients with papillary thyroid microcarcinoma. Background. Despite the guidelines recommending thyroid lobectomy, many papillary thyroid microcarcinoma, PTMC, patients still undergo total thyroidectomy. PTMC's optimal treatment remains unclear. We aim to determine whether total thyroidectomy improves outcomes compared to less extensive surgery. Methods. We analyzed 6,064 PTMC adult patients from the Surveillance, Epidemiology and End Results (SEER) database, 2000 to 2019, who underwent either total thyroidectomy, N equals 3,652, or less extensive surgery, N equals 2,412. Endpoints were overall survival, cancer-specific survival, and recurrence. Results. Total thyroidectomy patients had a 5.2% mortality rate versus 8.1% with less extensive surgery. Recurrence occurred in 0.03%, total thyroidectomy patient compared to 1.0%, less extensive surgery patients, HR 0.07, P equals 0.01. Median survival was 8.1 years for total thyroidectomy versus 8.8 years for less extensive surgery. Overall survival favored total thyroidectomy, P equals 0.001, but cancer-specific survival did not differ. Conclusion. Although total thyroidectomy may not improve cancer-specific survival, it lowers recurrence risk and confers an overall survival advantage for PTMC patients. These findings may help guide surgical decisions. Hypoalbuminemia improves the ACS-NSCOP surgical risk calculator for gastrectomy. Background. The ACS-NSCOP surgical risk calculator, SRC, is used to predict surgical outcomes, but its accuracy in gastrectomy has been questioned. 1,2 We investigated if adding hypoalbuminemia enhances its predictive ability in gastrectomy. Methods. We identified gastrectomy patients from the ACS-NSCOP database from 2005 to 2019. We constructed pairs of logistic regression models, one with the existing 21 preoperative risk factors from the SRC and another with the addition of hypoalbuminemia. We evaluated improvement using likelihood ratio test, LRT, Breyer scores, and C-statistics. Results. Of 18,070 gastrectomy patients, 34.5% had hypoalbuminemia. Hypoalbuminemia patients had 2.34 higher odds of mortality and 1.79 higher odds of morbidity. Adding hypoalbuminemia to the RC models statistically improved predictions for mortality, cumulative morbidity, pulmonary, renal, and wound complications, LRTP less than 0.001. It did not improve predictions for cardiac complications, LRTP equals 0.11. Conclusion. Hypoalbuminemia should be considered as an additional variable to the ACS-NSCOP SRC. Telehealth for general surgery postoperative care. Background. Telehealth utilization rapidly increased following the pandemic. However, it is not widely used in the veteran surgical population. We sought to evaluate postoperative telehealth in patients undergoing general surgery. Methods. Retrospective review of veterans undergoing general surgery, a Level 1 AVA medical center from June 2019 to September 2021. Exclusions were concomitant procedures, discharge with drains or non-absorbable sutures/staples, complication prior to discharge or pathology positive for malignancy. Results. 1,075 patients underwent qualifying procedures, 124, 12%, were excluded and 162, 17%, did not have follow-up. 443, 56%, patients followed up in person, 56%, versus 346, 44%, via telehealth. Telehealth patients had a lower rate of complications, 6% versus 12%, P equals 0.013. There were no significant differences in ED visits, 30-day readmission, postoperative procedures or missed adverse events. Conclusion. Telehealth follow-up after general surgical procedures is safe and effective. Postoperative telehealth care should be considered after low-risk general surgery procedures. Next article is from World Journal of Surgery. Pre-hospital hemorrhage management in low and middle-income countries, a scoping review. Introduction. Low and middle-income countries, LMICs, account for 90% of deaths due to injury, largely due to hemorrhage. The increased hemorrhage mortality burden in LMICs is exacerbated by absent or ineffective pre-hospital care. Hemorrhage management, is an essential component of pre-hospital care in LMICs. Yet current practices for pre-hospital and outcomes from first responder training have yet to be summarized. Methods. This review describes the current literature on pre-hospital and the impact of first responder training in LMICs. Articles published between January 2000 and January 2023 were identified using PMC, Medline, and Scopus databases following PRISMA SCR guidelines. Inclusion criteria span first responder training programs delivering pre-hospital care for home. Relevant articles were assessed for quality using the Newcastle-Ottawa scale. Results: of the initial 994 articles, 20 met inclusion criteria representing 16 countries. Studies included randomized controlled trials, cohort studies, case control studies, reviews, and epidemiological studies. Basic home curricula were found in 15 studies and advanced home curricula were found in 6 studies. Traumatic hemorrhage was indicated in 17 studies while obstetric hemorrhage was indicated in 3 studies. First responders indicated home use in 55% to 76% of encounters, the most frequent skill they reported using. Mean improvements in home knowledge acquisition post-course ranged from 23 to 58 percentage points following training for pressure and elevation, gauze application, and tourniquet application. Conclusions: our study summarizes the current literature on pre-hospital home mix pertaining to epidemiology, interventions, and outcomes. Home resources should be a priority for further development. Using heart rate variability to develop a predictive model for postoperative cardiovascular complications following major abdominal surgery, a pilot study. Background: heart rate variability, HRV, is a dynamic reflection of heart rhythm regulation by various physiological inputs. HRV deviations have been found to correlate with clinical outcomes in patients under physiological stresses. Perioperative cardiovascular complications occur in up to 5% of adult patients undergoing abdominal surgery and are associated with significantly increased mortality. This pilot study aimed to develop a predictive model for postoperative cardiovascular complications using HRV parameters for early risk stratification and aid postoperative clinical decision-making. Methods: adult patients admitted to high-dependency units after elective major abdominal surgery were recruited. The primary composite outcome was defined as cardiovascular complications within 7 days post-operatively. ECG monitoring for HRV parameters was conducted at 3 time points: preoperative, immediately postoperative, and postoperative day 1, and analyzed based on outcome group and time interactions. Candidate HRV predictors were included in a multivariable logistic regression analysis incorporating a stepwise selection algorithm. Results: 89 patients were included in the analysis, with 8 experiencing cardiovascular complications. 3 HRV parameters, when measured immediately post-operatively and composited with patient age, provided the basis for a predictive model with AUC of 0.980, 95% C, 0.953, 1.00. The negative predictive value was 1.00 at a statistically optimal predicted probability cutoff point of 0.16. Conclusion: our model holds potential for accelerating clinical decision-making and aiding in patient triaging post-operatively, using easily acquired HRV parameters. Risk stratification with our model may enable safe, early step-down care in patients assessed to have a low-risk profile of postoperative cardiovascular complications. Thank you for listening to This Week in Surgery, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.